Hello.
Man.
Uh, so yeah, I got a cord issue, I guess. Uh,
Uh,
looks like it's fixed for right now, as long as I don't get all excited and bang my plug-in too much. I think I'll be all right. So, all right. We just watched the video on the head transplant, though. I'll see if I could find it.
Oh gosh, I'm trying to get it in. My baked potatoes not lasting very long.
See what this person says.
Did you figure out what it's saying?
Yeah, for now. These people are saying the head thing. There's no way it could happen.
Well, I don't know. Where the hell did I get the head from? Because
From
usually
this Russian guy,
this Russian guy.
Yeah, there's a guy in Russia that volunteered.
because he has a rare disease.
To donate his head for the head transplant. Oh, he found
Well,
it?
that's what I was saying. It had to be from.
Donate this guy's head. It's not supposed to happen though until this December.
What will be the groundbreaking moments in the coming year? In late 2017, the world will await the results of a radical and controversial operation. Italian neurosurgeon Dr. Sergio Canavero, seen by many as a maverick, is set to attempt the world's first human head transplant.
A body transplant or a head transplant is a true first in medical care. Whether it can be performed successfully remains to be seen.
Yes, sir, I'm here.
Oh, Larry, hi!
But the surgeon has found a participant willing to take the risk.
A Russian man with a chronic and progressive neuromuscular problem has been considered to be the likely candidate for the recipient of the body transplant.
Valery Spiridonov is wheelchair-bound and his degenerative disease is terminal.
90% is the chance that Valery stands to survive the operation.
150 doctors and nurses would be involved in an operation that could take up to 36 hours to complete.
The proposition involves maintaining the blood supply around the donor body, but also critically maintain the blood supply to the recipient's head so that the recipient does not suffer a terrible stroke or brain death. To maximise the length of time that the blood supply can be interrupted, the recipient and the donor body will both be cooled to significantly subnormal temperatures to around 17 degrees or so. Once everything is cooled, then the donor body will be slowly dissected from the donor head, and at the same time the recipient head will be freed of its minimally or non-functioning old body. Critically, it involves cutting the spinal cord and grafting the donor spinal cord in the donor body onto the recipient's spinal cord and brain.
Doctors will have less than 60 minutes to reattach the head.
The spinal cord is to be glued together, followed by some hardware to screw the spinal column together, and then the muscles will be reattached. The patient will be kept in a coma for 6 weeks, presumably to allow the spinal cord to heal or knit together.
The procedure, which seems the stuff of science fiction, has been met with concern and skepticism by the medical establishment.
In theory, every step of it can be done, and there are some steps of it that are done routinely, but a spinal cord has never successfully been reattached before. Once the spinal cord is cut and repaired, it will not function, and we know that from extensive scientific studies and medical studies. There is an inevitability that the recipient will wake up unable to move the arms, legs, or any of the organs of the grafted body. So they will be unable to breathe and would subsequently die.
And there are other questions about the ethics of the operation.
There is a concern about the use of a donor body, which would normally be used for harvesting organs, being used on a project where there is very little medical or scientific evidence to support its use.
Dr. Canavero believes the transplant could be the key to everlasting life. His controversial plans will be watched with fascination by professionals and public alike in 2017.
This is going to be a big talking point because it captures the public imagination, and it is a fascinating medical procedure to devise and to contemplate. Will it be a medical success? No. But I'm happy to be proved wrong.
Because the doctor that's doing it thinks it could be done. You said there's a monkey head transplant?
Yeah, there was,
Hope the terminally ill guy is okay with dying.
Claims Maverick surgeons.
head transplants successfully performed on monkeys doesn't mean diagnosis.
Should never get facts from YouTube. Okay. Back to class.
We're gonna go watch that. Well, we're gonna give it right now, we'll give it in the back. Game plan still. 15 and 16 on Saturday. I was late, so I didn't know what I talked about. I'm sure it's still the one. You're already there, isn't you? Over here. Over here.
What?
Then I'll leave early Sunday. I will not be here Saturday.
I may not be here Saturday.
If I'm here Saturday, you better be here Saturday.
I might not be.
You're not gonna be here. I'm going to the zoo tomorrow. Supposed to be there before, but I took care of that.
Because I was being nice and I told Amber about it. You know, I just really can't sit at home in my pajamas.
It makes me feel bad.
I'm going to the zoo.
All right. So back to the GI assessment physical examination. Sorry for the. Oh wait, did we go live? Oh, what?
Ellen, can I have one of your, two of your names? I just
Yeah, we're-
ate something hot. I want some sweet.
We're live. Yeah. Sorry for the technical difficulties, but we're back. I'm charging. I think I'm good.
Thank you.
So observe patient's position. Once again, this could tell you something. If they're in the fetal position, lying there in the fetal position, most likely their abdomen really does hurt. So assess the abdomen. Inspect other parts of the gastrointestinal system and inspect vomitus or feces if available. That's one thing I don't get real excited about looking at. They're like, oh, it's in the toilet. Go look. Yeah, okay. I believe you. And it's red? All right. I smell it. I don't like to. I will every once in a while. But but you guys are gonna end up sticking a tube up there anyway and send them off to get a tube stuck up there. No, I know you don't. I said you're gonna send them off to get a colonoscopy. So I was gonna say something. On assessing the abdomen, whenever you palpate the abdomen, obviously we talked about auscultating and listening to it. EMS isn't real good about listening to it, but nurses like listening to it. Whenever you're assessing or palpating the abdomen, always start away from the quadrant that hurts and work around to that quadrant that they have pain in. What's that?
Dr. Buster would go to the source of the pain.
Yeah, you know, they say not to because you could cause it to move over. I'm not going to argue with the physician.
Does this hurt?
Yeah.
Does this hurt again? I think that hurt.
I just spilled water myself. Allergic reaction so immune system allergic reaction most relevant for EMS is anaphylaxis. There, you got to understand for somebody to have an allergic reaction to something or anaphylactic reaction, they have had to been exposed to the allergen to begin with. The body had to make antibodies to that. So if they're allergic to bee stings, they had to be exposed to bees bee sting before, or like with peanuts, you know, they've had to eat them before. The first time that you're exposed to it, you're not going to have an allergic reaction, but your body then makes antibodies, and whenever it's introduced, then that's when you'll have the anaphylactic reaction. Anaphylactic reaction is different than just a generalized allergic reaction. Generalized allergic reaction will be like a rash around the area, stuff like that. Anaphylaxis is typically will start to affect the airway, so they'll start to have the airway closed off, and that becomes a great concern for us. The good thing is, despite how expensive it is, we still carry the EpiPen. EpiPens are, you guys as EMT basics are able to use EpiPens, and so become. What's that?
Does yours talk to you?
No. Why does that one say it talks to you?
Yeah, it's the ones that talk to you.
Really?
Oh, step you through it. People that don't know how to do it.
That's kind of cool.
Once after they hear it, they want to do it. We don't. We've had them, and then we put them in the shop container and they stick things in the top.
Oh man, that'd be annoying.
It's probably reflecting off his helmet.
So history of allergies. If so, what typical reactions are like? A lot of times you'll get somebody that says, "Oh, I'm allergic to such and such medication." Well, what happened? Well, it made me sick to my stomach. That's not an allergic reaction. That's a side effect of the medication. So understand that. You always ask, what did it do to you if they tell you they're allergic to something. Symptoms of tightness in chest or throat, that's an anaphylactic reaction. Medications for allergic reactions. So we talked about the epinephrine. Perform physical examination. Expect points of contact with allergen. Inspect patient's skin for hives. Inspect the face, lips, and mouth for swelling. And listen to the lungs to assure adequate breathing. if you do run somebody, let's say they're allergic to bees, they're stung by a bee, and they're really excited and freaking out, and you go do your exam and you don't see any hives, you don't see any swelling to the mouth, you listen to the breath, they're clear. I wouldn't give the EpiPen. I just hold off and evaluate them, watch them, and make sure that they don't develop. We had one out here that did that. He was allergic to wasps, freaked out whenever he got stung, and we brought him in. We didn't never give the EpiPen. He didn't need it, so I got a little excited about the whole ordeal. So, musculoskeletal system. So, medical diseases in the system are rare. Bones are the most important aspect to assess. So, with us, most likely, when we're doing bones, we're assessing for fractured bones or deformed. Deformity is an important word to learn. If you go and you say the second you say that something's broken, you're going to find out that it's not in fact broken. It's just dislocated. What's that? Do you have one?
Well, they have Christmas away family.
Yeah.
I got 2,000 up on that. I already had you in pickup.
Yeah, might as well take him.
Calf kick you.
Oh yeah. In the leg?
Mhm.
Oh, ouch.
But that's not it. Yeah, he called for me, because I walked out with him, and I come back, and he said, "It's broke." And I looked over at him, and I was like, you could see he was holding his leg up because his knee was bent, but his foot was flat down on the ground. I was like, and then we get here, and they was like, is it sticking out? I was like, I don't know, he was thinking so much.
So the sticking out you mentioned is a compound fracture. Whenever the bone goes through the skin, as an EMT, please try not to pull that bone back in into the skin. You're introducing infection. Now, if you have a mid-shaft femur fracture, you can pull traction and pull it back through. Yeah. Yeah. But try not to. If otherwise, don't try to pull the bone, get it to go back through the skin. Most likely, it's just gonna come back out. So with traction splint, we're pulling it back through, and then it's gonna hold it there. They're gonna go in, and whenever they do surgery, they're gonna clean that all up anyway. So. Musculoskeletal assessment history, so prior injuries, whether patient takes blood thinning medication. That's important, right? So we have a compound fracture, and now it's going to be a bloody mess. The other thing is sometimes just because you don't have an open wound doesn't mean you're not bleeding. So you have you break your arm, and that arm cuts a lot of blood vessels, small blood vessels, and you'll bleed quite a bit. At pelvis, I think a pelvis could hold up to 1,200 cc's of blood, which is a lot of blood. So, and then all of a sudden you get all this swelling in places that you really don't need it. So, what's that? History to determine if a medical problem caused the traumatic injury. So, sometimes you'll run a call where maybe they had a syncopal episode, and that's what caused them to fall. So don't always just get tunnel vision on the fractured extremity or whatever. And, hey, what caused you to fall? Oh, I got really dizzy and blacked out. Oh, okay. So now is this a trauma or is this a medical? Or both? And which one's probably more important? It's a good chance that it's the medical. Take a blood pressure and you have a real low blood pressure. We have more of a medical issue than we do a trauma issue. Medical assessment examination. Inspect for signs of injury such as deformity. And like I said, that's a key word. Even mid-shaft femur fracture, you'll report that as deformity noted to the mid femur. The reason I say that is because we don't have X-ray vision. We can't say it's actually broke. I've had some very gnarly looking deformity that I just knew was broke. And it was a really bad dislocation, really bad. So, not just because that could be as bad or worse than the broken bone. Rebecca probably could tell us more about this stuff than I can, but she works with these things, assessing these people and fixing them. So. Palpate areas with suspected injury. Obviously, you want to feel it right. Compare sides for symmetry. One thing that I could think of that that really sticks out for symmetry wise is whenever you have shortening of a leg, one leg or another. A lot of times that you have a hip fracture there. Be alert for crepitation. Crepitation is the sound made. Oh yeah, no, me too. Whenever the bone ends rub on each other, it's a grating, disgusting feeling, especially when you're not ready for it. Yeah, crepitus is gross. We found a guy. He was a homeless guy. We ran him a million times. Got anything going on today? No. We just want to go to the hospital. Okay. And he's always drunk. So I go to pick him up because he's not going to get up on our cot. I go to grab him by the arms and pick him up. When I do, I had the two bone ends in my arm. It's like, I was like, ugh. Put him on, and he's like, oh. I was like, why didn't you tell me that you broke my arm? Because I'm tough. I don't care how tough you are. Yeah, and the X-ray was very impressive. But whenever I was like, oh my, and I looked down, and the point of the humerus is coming. It didn't come through the skin, but I could see it. I'm like, I'm gonna cause a compound fracture on this guy. But yeah, it was. Yeah. So anyway, crepitus is gross. Assess patient head to toe if there are multiple injuries of the patient or if the patient is unresponsive. So whenever we start going over our trauma assessment, you guys will do a head to toe. You guys will actually do a rapid head to toe or rapid assessment, I believe they call it. You just go and you feel each thing. You're just going to know any deformity, crepitus, or anything like that. So, and you want to do this on your unresponsive patient. So this homeless guy, I talked to him before. I wasn't expecting any injuries. He didn't report any injuries when asked. And so I still felt bad, but there's nothing else I could have done. What's that? Yeah. So secondary assessment of the medical patient. So that was trauma. These chapters are long. You guys are gonna have to read it, get to know it. Hopefully, it all makes sense whenever we do a patient assessment lab, which won't be Saturday. We won't do any lab Saturday. We'll just finish. If we don't get all the way through 14 here, or is this 13? No, 14. If we don't get all the way through 14, we'll finish 14 on Saturday. 15 is not all that long. It's charting. I'm going to tell you a few things on charting. And then 16, we'll get started in it, but I don't. It's the introduction to medications? How long is it? Okay, so we might get through 16 on Saturday. So we'll just have to see. So the medical patient, like I said, these are more difficult patients than your trauma patients. With your medical patient, you're trying to fit this puzzle together, whereas a trauma patient, you kind of have what's going on right in front of you. So, assessment varies depending on patient's ability to communicate. Responsive medical patient focus on chief complaint, and unresponsive medical patient focus on physical findings. So if you have a patient that tells you they have chest pain, obviously we're gonna. Are you guys cold? That thermostat must be broken. So if they complain of chest pain, you're going to then kind of focus on chest pain. So, with the unresponsive medical patient, focus on the physical findings. So things like blood pressure is low, or blood sugar is low, or different things like that. When you're going to do your exam, feel their skin, or they're cool, diaphoretic, and go through it. I'm not sure if they will. If they don't, I will kind of give you some ideas of some questions that you do want to go over, like on chest pain and things like that. So we'll see if they do. The responsive medical patient, take a history of present illness, take a past medical history, perform physical exam, and obtain baseline vital signs. Administer interventions and transport the patient. So your history of present illness, you can use, or you do want to use your OPQRST history on it, then take medical history, use your sample history to obtain a lot of that, and then perform your physical exam. If this is something like a chest pain call or difficulty breathing, obviously we're going to focus there, so we're going to listen to breath sounds and things like that. Take a history of the present illness, so obtain from the patient, obtain from family or bystanders, and ask open-ended questions. Hey, what's going on today? Oh, I just don't feel well. Now, sometimes your bystanders are the only people that can help you out. The kid was walking, and all of a sudden he just went down. We don't know what happened. Whenever they're talking about history, take a history of the present illness, you're just getting the story of what's going on right now. And whenever you get to charting, your charting software does a really good job of putting this information in your chart for you, but it doesn't tell the story. You need to make the chart tell the story, and that's where your history of the present illness, it becomes very important. So, chief complaint: why patient activated EMS and what is bothering the patient most? So, our common you hear it all the time, and I've said it a million times in here. Walk in, hi Ellen, what's going on today? What made you call EMS? I'm just, I'm short of breath. I can't catch my breath. It's been going on for about 4 hours. It's just continually getting worse. Okay. Or if, she said, you could ask her, is there anything that makes it better or worse? Well, yeah. If I just sit here still, it's okay. But if I get up and go to the other room, boy, I almost pass out. And so you want to keep those questions open-ended. Now, one that you don't want to keep open-ended, you want to structure is, what's your past medical history? Because with a lot of times, especially some elderly patients, man, they'll start rattling off dates. Well, in 65, I had my first child, and followed in 68, they had to go back in and fix the scar tissue. And then 73, and you're like, okay. And so, you'll hear a lot of medics say that they're having chest pain. Do you have any history of like diabetes or stroke or anything like that? So that you're asking about more pertinent history, that's more current and things like that. So be careful with it. Onset, what are you doing when the pain started? Provocation, does anything trigger the pain or make it worse? Quality, describe the pain. Sometimes they'll say, what do you mean? And then you kind of give them, well, is it a sharp pain? Is it a dull pain? And so I don't typically start out with, is it a sharp pain, dull pain? Because I feel like that's leading them down a road. But hey, can you describe your pain to me? Or what do you mean? And that's when I'll go ahead and kind of give them some. So region or relief. used to be radiation. They changed it on me. So region of relief. So where's the pain? Does it seem to spread or shoot? What the? I like my radiation better. But understand that probably the new stuff is using region or relief. Where is the pain? Does it seem to spread or shoot anywhere? Severity. How bad is the pain on a scale of 1 to 10? 10 is that real popular scale. 1 being the least, 10 being the most pain you've ever had in your life. Whenever they're calm, not sweating, and not writhing in pain, and they say a 10, yeah, okay. You do realize what 10 means, right? So, time. When did pain start? So then your sample history, symptoms, allergies, and we always said signs and symptoms. Allergies, medications, or pertinent past history, last oral intake, and events leading to illness. If I was you guys, I would write down OPQRST and sample and just get to where you could fill those out without even looking at them. I'm fairly certain that you will get OPQRST and sample history questions on your National Registry test. Okay. Oh, you've already done the test.
Everybody's overachievers in here with fun stuff.
You guys are doing fine. You need to pick it up.
I'm like Crystal, the chapter is long, but the test is.
It's fairly easy. Yeah. The chapter is a very pertinent chapter. Very pertinent to EMS. I told you guys I didn't think that their anatomy and physiology chapter. I didn't feel it was very pertinent. Some of the information is good, but I feel like this is a very pertinent chapter. It's just not. It's not hard. It's just long. It's a lot of what you do. Tailoring the physical exam for specific complaints. Important information can be gained by tailoring history to patient's chief complaint. Ask questions pertinent to chief complaint. Do they give you examples in the book? I'm not sure if they're going to in the slides. I just want to know because, like one thing that was hard for me, and I had to learn once I got out of my EMT school, even back then paramedic school, was on like chest pain. What's important questions to ask for chest pain? And what are questions that maybe can wait? So one of the things was last oral intake. And I feel like last oral intake, if you're dealing with a cardiac issue, it's important to find out because you want to differentiate between, could it be gallbladder, indigestion, or whatever. If you're really focusing on chest pain, there's questions like, does it radiate anywhere? Does it go into your back? Have you ever had do you have a cardiac history? I'm trying to think of all of them. Are you nauseated or have you vomited? Are you short of breath? These are all geared towards those chest pain questions. And guys, you want to take note of pertinent negatives. What a pertinent negative is are you short of breath? No, not really. Or have you been nauseated? No. Those are very pertinent negatives to ruling out, or not ruling out, but maybe reducing the severity of this possible cardiac chest pain, because they're not having these signs and symptoms. So maybe we can start going down, well, what did you have to eat today? Oh, I had 4 tacos and a 7-layer burrito from Taco Bell. And you're like, okay. So for me, the reason I was asking if there's a chart in there for kind of these more focused questions was because they never really gave us good focused questions. They just told us we need to do it. Well, okay, scratching my head. Some other things, if you're thinking of chest pain, one thing you want to do is you want to palpate around in the chest. Can you show me where it hurts right there? Okay, and you push on. Does that make it hurt worse? Oh, yeah. Yeah, so have you been doing anything lately? Well, we did dig a 50-foot garden by 50-foot garden yesterday with a trowel. Oh, okay. So now you kind of, rule out that chest pain. It's probably, but guys, don't be tricked by that. I've had actual cardiac related chest pain in STEMIs that I pushed on their chest. Oh yeah, oh that hurt. I don't know what caused that. I don't know if it's a combination thing, but I've had that before. So don't just completely rule it out. But if you can kind of narrow it down, there's a good chance that that's what it is. They're working in the garden. So. Ask questions pertinent to chief complaint and then body system approach. Focus questioning and examination on particular body systems most likely involved. So this is something that you're doing on the medical versus the trauma. You're doing that rapid head to toe or your head to toe assessment. So, pediatric note: get on same level with child. Put questions in simple language. I'm going to tell you this: put questions in simple language even to your adults. I mean, I'm not saying super simple, but always try to remember that not everybody even knows simple medical terms. And I am guilty sometimes of just completely forgetting it until I see them going, oh, sorry about that. And so, but getting on the same level with a child, when you tower over them, we talked about it already, kind of scares them. So gather information from caregivers. Typically, moms know everything about those kids. Dads, we know some stuff about the kids. We try to know about the kids, but moms are really good about it. Perform a physical exam, usually brief, and then examine areas of concern based on chief complaint. So if they're having, abdominal pain, let's say lower left quadrant, are we really concerned with, making sure that they don't have any pain in their chest, like palpating their chest? Yeah, if you got time, you could do it, but you're going to concentrate that on the abdomen. Sometimes you can have the referred pain, but blah, 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 blah. Auscultate to listen for presence and absence of lung sounds. Absence of lung sounds, not good, unless they don't have a lung on that side. Obtain baseline vital signs, essential to assessment of a medical patient. Later assessment of vital signs will be compared to baseline. And then you start developing your trends. Administer intervention and transport the patient. Remember, a decision for prompt transportation of critical patients or those with specific complaints is part of a treatment plan. All right. So, but don't make that your only treatment plan that you do on every single patient. I'm having shortness of breath. I have some swelling in my legs. Let's go real fast. No, you guys could treat that. CPAP. So, where would you focus your physical examination on patient complaining of shortness of breath? On their big toe, definitely. If it's swollen, you have CHF. So, now, obviously, we want to concentrate that in their chest. We want to listen to their breath sounds and things like that. So other things that if you're going down that route, you have a history of CHF, you might look at their feet, feel their abdomen, and things like that. Now listen to their breath sounds. They get back up into their lungs. Yes, definitely. Any weight gain. They retain that water. They get heavy. So, I've always been so surprised how heavy they get with that weight gain. Yeah. So unresponsive medical patient, begin with physical exam and baseline vital signs, then gather history from bystanders or family members. I would probably do these simultaneously. I wouldn't say then gather. You have a 2-person crew. You need to be gathering that information. So sometimes time is of the essence. So, do rapid assessment of entire body. Similar to head to toe physical exam for a trauma patient, it says it's head, neck, chest, abdomen, pelvis, extremities, and posterior. And we will do some with our assessment lab. We will do some palpation, what you guys are feeling for, and things like that. So neck, jugular vein distension, medical identification devices. We used to have 5 pieces of information that we look for. JVD, med alert tag. So jugular vein distension, med alert tag is stoma. And I know that the Rice Krispies, subacute emphysema. There's one more, tracheal deviation. Yay! 5. Yeah. Now they're just having you guys look for 2. I would look for more than 2. And if you ever find subacute emphysema, it's really fun. Subacute emphysema is typically due to a collapsed lung on one side or the other, usually involved in some sort of traumatic event. And basically what it is the air has been pushed up to the skin, and whenever you push on it, it feels like Rice Krispies popping. It's like, it's pretty cool. And then you say, oh no, get ALS. And then we'll stick a needle in their chest and let that out. It's all kinds of fun. Unless it gets clogged up with blood, and then we can't do anything. That's no fun at all because they get that patient somewhere fast. Chest, you're listening to breath sounds. Abdomen, feeling for distension, firmness, or rigidity. Another thing that you want to do on the abdomen, maybe not necessarily on this patient, they haven't really talked about though, is look for guarding. If you palpate on it and they guard. And the other thing is if you find a bulge in the center of the abdomen that's palpate or pulsating, has a pulse, and they're complaining of a stabbing pain in their abdomen or back, get them somewhere very, 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 very fast. All right. The bulging mass in the center of the abdomen, a pulsating mass in the center of the abdomen is most likely a dissecting aortic aneurysm, and they're going to die soon. Don't let them go poop because they'll feel like they need to have a bowel movement, and then you're going to be coding them, and what you're going to see is they're just going to turn sheet white. So I don't know if they have that in your book when you're assessing the abdomen. That's a big one. I've had a few of those in my career. Kind of crazy little old lady sitting on a bench at a Homeland or something like that, at a grocery store. She got weak. She sat down. They called EMS. We get there. I'm doing my assessment. She wasn't even complaining of stabbing pain. Do my assessment. I feel in her abdomen it's like, boom, boom, boom. And she's like, boys, I think I'm feeling a little better sitting down. I think I'll just go home. We're like, no, man, you need to go to the hospital. She ended up dying. We got her to the hospital. They were taking her up the elevator for surgery, and it ruptured on the way up. She died. If that ruptured before they're ready for surgery, their chances of survival are very small. So look for it. Pelvis, don't play with it. If you find it, don't play with it. So pelvis, incontinence of urine or feces. Yep. So extremities, pulse, motor function, sensation, oxygen saturation, medical identification devices. They've added to the PMS, so pulse, motor function, and sensation. They've added oxygen saturation and medical identification devices. So, on your assessment of your extremities, it's important to do that. And like we said, if you have like a fractured leg or something like that, deformity of the leg, and you find the pedal pulse, mark it with an X. A couple things could happen. One, it could start to swell and become very difficult to find. Number two, are you moving them and stuff? You may block off that artery, and then they don't have any pulsation, and then they're going to say, get them out of here quick. They need to get out of here quick. They have about 6 hours to restore that circulation. And whenever you're talking about the medical world, that's a very short amount of time, because that's getting the transport set up. That's getting an hour in the air. That's getting the surgery suite opened up. And so that 6 hours is a very short amount of time. Check for medical ID devices. Tell you a lot about a patient. Find somebody unresponsive. Oh, hey, look, they're diabetic. Or hey, look, they're allergic to bees, and they were gathering honey. See, she gathers honey and she's allergic to bees. You gather honey? Crazy. You get stung? You just give yourself.
As long as it's armpit down, I can manage it. Just like on the book, just relax. Sometimes they get me on the hands, I have to watch it, because it looks like little arms.
Yeah.
And then it starts going, but I do it for so long that I don't know how to take it. There's something that's coming, I know it's good.
You pet the bees? You reckon?
I had crystal drills, actually my daughter had crystal drills holding me to rain, not the only, but it's not good.
Oh, really? Do they get stung? You smoke them?
We do that. If we're gonna mess in the hive, we smoke it.
Yeah.
They think their house is on fire, so they go run down. And then they're like, yeah, if they don't go down on all the honey. They don't.
Bees. They're cool. I wish I had some bees. You want to give me some bees? You could?
It's one season right now, so.
All right. So anyway, going on. Off topic with the bees. And then check pupils. I've already said 1,000 times how important I think pupils are, especially on an unresponsive patient. You check their pupils are pinpoint. You guys know you can do something for them. Assess pulse, so obtain baseline vital signs. Assess pulse, respiration, skin, pupils, blood pressure. Take note of any abnormalities. And when they say take note, it's not write it down. It's just take a mental note. And make sure you pass that information along. You drop them off at the hospital. You guys are going to have to learn how to give a good report. I've already talked about the fact that giving a good report builds good rapport with the hospital staff. And the more times that you go in, you're going to bumble at first. I still bumble sometimes. Like, but if you're able to tell them what was going on, some good information that you found at the house, it really helps them out. And then they start to appreciate that. If you just go in and say, "Oh, here's Bertha," and throw her on the cot, they're like, "Well, okay. So what's going on today, Bertha?" And they have to do everything you've already done. They're going to do a lot of it anyway. Don't get offended by that. They have to do their assessment too. And you'll be amazed. You're standing there, and they're asking the exact same questions you did, and they're getting different answers. You're like,
And then when the doctor comes in, even more.
yeah. You're like, no, you said you didn't hit your head. Now you're saying you crushed your skull and but
Call the doctor, give a report. The doctor comes in and the story changes and he says, well, what?
nurses will look at you like that too until it happens to them, and then they're like, you get a seasoned nurse and they know. Yeah, they know. You know, and sometimes it's not even a lie. It's just whatever reason.
They don't want to tell the truth, the truth is wrong.
Yeah, there you go. White coats. So consider a request for ALS personnel. Obtain baseline vital signs. Consider a request for ALS personnel. Depends on geographic options, types of facility available. I could talk all day about Roger Mills, and it's a very unique geographic location. Logistically, 1,100 square miles. I'm not going to. Just if you get a serious patient, you need to consider your best option. Is your best option to drive to Roger Mills or Elk City, or is your best option to call for an ALS intercept? Do you have that available to you? Is that available to you? Is there evac available to you? Is a paramedic ground service available to you? And don't call their evac for pregnant. If they're imminent delivery, they're just going to ride in with you. They're not going. They can't fly it because they don't. Number one, they don't have the room to deliver the baby in the aircraft, and number two, they don't have the equipment to take care of baby and mom. Take a history of present illness and past medical history. Question bystanders. What is the patient's name? I don't know. What happened? I don't know. Did you see anything else? No. And I'm just telling you what your typical response. Did the patient complain before this happened? And does the patient have any known illnesses or problems? Is the patient taking any medication? Sometimes bystanders know. The last one, you'd be amazed how many spouses don't know the last one. I don't know. She might take some medicine she got from the. I don't know. It's amazing. You're like, you are married, right? So, anyway, yeah, no. Oh, it's a pharmacist. No, she takes some stuff, but it's more of for like shoulder pain at night, stuff like that. Now I take all kinds of medicine. I'm not hungry. I got Crohn's. Administer. So back to that GI section. Yeah, I got that. Which is funny because I don't have any. I take my medicine. I'm fine. Anyway, administer interventions and transport patient. Look for mechanism of injury or signs that suggest a spine injury. If needed, immobilize the patient's spine. Even on your medical patients, right? Syncopal episode, fall down, crack their head. Probably need to put a C-collar on it. Slid out of their wheelchair onto the ground. Probably not. Use your judgment. Slid out of the wheelchair on the ground, hit their head, complaining of neck pain. I'd probably go ahead and put a C-collar on. You guys are it's getting to be more and more of a judgment thing with things like that. But don't get lazy. I have some lazy EMTs. Reasons why they don't do what they should do. Well, I thought about doing that, but if you think about doing it, if it crosses your mind, one thing I've learned, if it crosses your mind, you probably should have already done it. So.
They come in their package and we let them out before we do anything.
Yeah.
We don't.
And all of a sudden you find out they have a cervical spine fracture. We brought a lady in here one time. I would have swore that they were just going to send her home. She rolled her vehicle. I extricated her out. I actually took the time to cut the roof out and stuff. But it's one of those that gut instinct that, well, it's a rollover accident. We're going to take every precaution. Skull fractures. Did she skull fracture back? Did she have a spinal? A neck? She had a lot of injuries. It was amazing. No, she leads like the wide load, does a wide load sign.
Oh, yeah, okay.
So anyway, you erase your text messages too before you hand the phone to the paramedic and have them call your boyfriend. Oh my gosh. Dude. Some things just can't be unseen. What? What's her name's here? So how do you keep a straight face when you see that? Anyway, moving on.
The reason for the car accident.
Could be. If you think about it, you're like, should I? You probably should be doing it. Mine are more either drug or intubation related. Oh gosh, maybe I shouldn't. No, we'll make it to the hospital just fine. We get to the hospital and they're freaking out and they're intubating. I'm like, oh shit, I should have intubated. And so it's one of those things. If you should do it. So think about it. What other mechanisms might you have to obtain? I cannot read or talk tonight. I'm fairly certain I had a stroke. So think about it. What other mechanisms might you have to obtain patient history other than speaking to bystanders? We kind of talked about some of them, med alert tags or things like that. And sometimes just your examination. You will come across a patient that you have no information on. And what you do on those patients, they're unresponsive, you have no information. All you can do, one is look for a med alert tag, to do your assessment. You start with your vital, you get your basic vital signs. Obviously, you're going to go through your ABCs and all the other stuff, but your vital signs, and then to include blood sugar. Sometimes you're just not going to be able to find out what it is. So you're going to support the functions that keep you alive. You're going to support the airway, breathing, and circulation. You're going to watch your vital signs and you're going to transport. You're not ever going to know what it was. Now, with that being said, if you transport that patient and you get here and their blood sugar's 31, not that you guys are going to be in trouble because you guys are just basic, but like somebody that started an IV and give them dextrose, you could at least call for maybe an ALS intercept, or at least tell them when you walk in, hey, their blood sugar's 30, and be able to tell them. Versus, we found this patient unconscious, here they are. You're able to tell them, the story, and maybe tell them the blood sugar's 106, and that helps them out too. That hey, we need to be looking at other things. But anyway, those are some tools you have. Oh, and you can look at their medication, but he's looking at their medication, so you can tell a lot from a medication bottle. Problem is, everybody has them in their little med planner, and you can't find the bottles anywhere. So you're looking at a thing full of pills. Good luck. Call their pharmacist. Yeah. The grocery store plastic bags. Medical history. Interview family and bystanders for information about the present illness, OP-trustee, and also sample history. Another thing, some fire departments did a very good job of doing the vial for life or file for life, different things. The problem with those programs is we kind of forget to maintain them and keep them up, and so then time goes on. I couldn't tell you whether it's a file for life in a file somewhere, or a vial for life that all information's in a vial in their refrigerator, in their freezer. And so if a community does a program, those are really good programs, but they need to alert EMS so that the program's going on, because that's who uses that information. But two, continue it, maintain it and continue to do the program. Wichita was really good at the vial for life, and that it was in their freezer. Go to elderly people's house, they go to their freezer, and so many people had it. It's so easy. You pull it out, you have all their medical things. One of the problems with those is they did it in '86, and it hasn't been removed since. And since '86, they've been put on 42 different medications. So.
My dad has a sticker on his door. And he has a big sticker on the freezer door, and it lets everybody know that's what they're doing. It's bright jar in the freezer.
Yeah, and those are a good plan whenever people will execute. A lot of times they'll get. We can't hear you. Yeah, whatever. I don't even know who that was. I guess I should open the text later.
That's what maybe some more people do. Like colors or shit, that's what
the programs are awesome whenever they're utilized like that. The problem is whenever we go there and they don't want that sticker because it's not very attractive on the door, they don't put the sticker. They don't put the sticker on the. Well, now I don't know that there's a file of life, a vial of life in the freezer, and so That's awesome that your dad does it.
They told him that he could put it anywhere, like you could put it on the porch.
Uh-huh.
You put it anywhere just so that it's seen as they're walking up.
Gotcha.
And he could put it on the porch too, like there, but
Yeah. No, whenever the patient will actually do all the steps that are required, it's a very helpful tool. Especially whenever they have a medical condition, like let's say type 2 diabetes. It may be, yeah, and you know, we know about the brittle ones and the ones that don't take care of themselves. We don't really get to know the ones that control their diabetes and take care of themselves. And so that's a really good thing to have for somebody that's in that position. They take care of themselves. We get there and like, oh my gosh, it's unresponsive. You know, it's obviously we better check their blood sugar. It's, you know, kind of what we do. But you know, it does help a lot whenever you have that information. We already watched this video.
he
Move on.
goes to the doctor every 3 months to check his kidneys and stuff. And his doctor actually sends him out a paper that he switches out
Oh, nice.
in the refrigerator. Keeps the, sometimes she has to change the medicine a little
Yeah.
bit, and that printout has all of that on it, and he just switches the paper out.
It's 8. We went a little longer because we started a little longer. So we're at mid-chapter review.
So this is the first.
That's just no. There's like 3.
We are on slide.
There's 3.
I think it's 3.
We're on slide 59 of 164. So let's take a little break. Get up, stretch your legs. I need a drink of water.
No, like when you drink
I really don't drink that much. It's just plain. But get up, get a drink, stretch your legs. We are on slide 59 of 164. No, I never said I didn't believe you. I just said it wasn't hard. I need some water. I think that might
Are we staying here until it's done?
Yeah, we're gonna stay here till it's done.
I'm being serious.
No, I don't know. We'll go. We'll probably go.
Depends on her because she's my ride. Because if so, I'm gonna try to get me some fruit brought down here.
I'd like to get a little further than 60.
That's fine. No, it's take long. No. We don't have school tomorrow, no kids in school tomorrow. So that ever be a piano, go to piano. I gotta go to Sealing to piano concert. Did you ever find any more radios? Did you ever look?
I get 50% things done.
I thought if you hire me, I need a job. I'm a college student. I'm a good secretary. I'm really good. After you go through this course, and you will go be a paramedic, how long will it take you? How long will it take you to get there?
Paramedic. There's a lot of different programs out there. I think there's something
I'm just curious.
So I can't talk on that.
Well, because you're already learning the basics, and then,
You're in those up in all these.
Yes.
I can't talk about comforters, I don't know. Kansas, we have all, we have to have all the same prereqs as nurses. So once all the prereqs are done, you can either do nursing or you still want to do
I'm in back.
paramedic.
Yep.
I was actually in nursing school and got my, then I got to spend paramedic stuff off nursing. And at that point, at that division point, you have your year and a half of prereq. is my program is another 18 months. And what it, like nursing program, they follow like a college schedule. And if there's whenever it's all, ours was 18 months straight through. We didn't get any worse. 18 months straight through.
So that's why my radiology is really good. I don't get any breaks.
Yeah.
I go summer and everything.
What we do.
Fall, spring, summer, fall, spring, summer, spring, out.
And it's just, there's so much more with doing the paramedic that I'd say get your advance. And if you're really interested in
I don't know if I like it or not, we'll see.
this type of career, I would look at doing nursing.
So I'm gonna do it,
I think here's the thing about nursing, everything's kind of boring, but nurses have so many options. So you could do a year in the ICU and fly. But if you like EMS, fly. You could, depending on what state you're in, you could work on transfer service. Depending on what state you're in, you could go to Kansas and really basic, you could do run as a paramedic. You get sick of doing water mills in a hospital or stuff, you go somewhere and do ER. You get sick of the ER, you still do pediatrics.
So I'm gonna do the radiology deal and I wanna go to the ultrasound. I wanna do the ultrasound.
You have to partly do radiology. You have to use a medical. Reason for in Thomas Center, out in the hallway, outside the waiting room, and on
I called over to Elk City I gotta do an observation, the 8-hour deal. And I don't know the lady's name, I didn't put the phone, but I'm gonna go through the phone and contact. He was rude and hateful. And I was like, that'll probably be the time I get
with
stuck.
nursing, there's there's a lot of different things you can do.
I just don't have the heart to go people when they're going to die.
You don't need paramedics.
Well, we already know the nature of their injury. Or, they're being called for a reason. This is a medical emergency. But those that don't know anything, they're just like, this is like my stepmom got diagnosed with breast cancer the other day. Nothing in the world wrong. Went in for her deal, mammogram, and boom. And I was like, I don't want to be that person.
Well, you could do
I really wanted to be a lab tech, but that was 4 more years of school. I was like, I ain't got 4 years. Definitely going to stick and people with needles, drawing blood and stuff, and learning all the pathology and stuff. I would really love to be a surgeon, but that first cut would kind of freak me out a little bit. But afterwards, I think I'd be good. So you learn how to handle it.
I'm in such a great anatomy.
I watch it all the time.
Love it.
It's funny because since I went to the medical terminology, I'm like, hey, I don't really know what they're talking about now.
You understand more.
I don't know what you're saying.
Just imagine the setting they have to work.
They don't study nothing. They just read a script.
I would want to know what that's reading.
They don't care. They're just reading a
I
script,
would want to
making
know what I'm
money.
reading now. I know there's a few more. But now, I'm just thinking it all, they do it all. Danielle, you first
I need to pull those sheets out and see how many things.
she goes to the city and works up there.
The registered nurses that travel to the ER is what makes the money.
And then she.
Isn't that right, Rob?
What's
The
that?
traveling RN.
She works
Yeah, they make pretty good money. Contract nurses make good money too. I have no idea.
What do you think the it was?
Okay, I ordered something to eat, so I'll make it up in a little bit of cup of tea.
Okay, well, we're getting ready to be done with class.
Are you serious?
Go for
Huh? Done?
we'll go for
Tonight?
20 more minutes.
I'm joking. We got food coming in. We're going for another hour.
You guys can.
Then take off.
We probably
pharmacology.
should stay right here.
Take off pharmacology on Saturday.
Take our test. I got my iPad and my computer. I got
Silver
pictures.
says it's cheap to get kicked out of class. They cheap.
So here's the real issue. I'm having some serious technical difficulties.
You know, if we did it in the conference room, and then you have that fancy screen up there, then you have that.
No.
And we have more room for the dummies.
No, I'm not taking my dummy.
Yeah, I think you're done over there.
I'm not. The thing is that I have to lug it over there and lug it back. I lug
Like
it.
it, it's on wheels.
I'd have to push it over.
Push it over there, how, push it.
Well, I'm not saying that. I'm just saying that's fine.
That's like, oh, no.
There's an emergency unloading. Emergency, ring the bell.
All right.
Actually, a suggestion that I was supposed to tell you about the weekend. Started as an EMT, worked all the way up through RN,
Uh-huh.
that we should be strapped to here and taken for a helmet ride in English, just so we know what it's like.
So the nice thing about strapping people to gurney, and I don't do it to students, I don't do it to EMT students, but we do it in an EVOC course. And the good thing about it is it shows the driver how much just a little break affects your patient. And so, yeah, it's amplified in the back. And so, yeah, no, I do that. Yeah, and another thing is try not to use brakes. Anticipate everything. Coast, light brakes, light accelerator.
Fixing the turn left.
My one of my common things I'll yell is, "This ain't your emergency. Slow down." So, friggin' drivers. So
I make a good one. I got chewed out on the way to the hospital that night for not getting there fast. I was like, it was that time of the night, your headlights didn't help you see me, and I was like, there was fear out, and I didn't want to slam on the brakes. I would love to do it in
So my
I'm a good driver.
my cord's messing up, so I'm gonna try to get about 20 minutes out here, 20, 30 minutes ish, and see how far we get. I'm hoping to get to. No, we'll get through it. We'll get through it. So I'm gonna reduce war stories and explanations, and I'm just gonna go. So the secondary assessment. God. The secondary assessment of the medical patient takes two forms, depending on whether the patient is or is not responsive. You assess the. Do what?
Oh my gosh.
Oh, you're not cold? That's it. You assess the responsive patient by getting a history of the present illness and a past medical history, then performing a physical exam of affected parts of the body before getting baseline vitals. You guys will learn more of this or get the flow of it whenever we go over the skills check sheets, which they help out a lot. Since unresponsive medical patients cannot communicate, it is appropriate to start the assessment with a rapid physical exam. Baseline vital signs come next. Then you interview bystanders, family, and friends to get any history that can be obtained. Obviously, you're still going to do the scene size up, ABCs, and then move on to what they're saying. You may not change any field treatment as a result of the information gathered here, but the result of the assessment may be very important to the emergency department staff. What the fuck is this? I don't even get that. You may not change any field treatment as a result of the information gathered here in the. Okay, so you. Yeah, I don't know what they're saying with that sentence. Does anybody have an idea? Because I'm hoping that you're going to change things if you find things that are wrong. Oh my gosh, their blood pressure's in the shitter. Let's put a blanket on them and treat them for shock. Oh, okay. Yeah, no.
I know.
So,
Extra, no.
yeah. Rob says no.
Rob says no. Rob
Ex-
says no. There, then look.
All right, then. So secondary assessment of the trauma patient. So secondary assessment of the trauma patient. Injuries can range from slight to severe. To determine how serious an injury is, consider location of injury or injuries on patient and patient's mental status. Makes sense. Determine how serious an injury is, consider patient's airway status, vital signs, mechanisms of injury, patient's age, or pre-existing conditions. We already went over a lot of the mechanisms of injuries of like car accidents, but let's use like a fall from a ladder and things like that. You're going to use things such as what they fall onto, what part of their body did they hit when they fell. If they fell off a ladder and hit their feet and it was on a soft surface like water, like they fell off a ladder 20 feet into some water, it's probably a lot better than if they fell and hit their head on concrete. Assessment is focused on areas patient notes are painful or that the mechanism of injury indicates. And if I don't know if they have this, areas that you find trauma in your head to toe. So determine the chief complaint, conduct a history of present illness to gain information on how injury occurred. What the patient tells you, so determine chief complaint. Chief complaint is what the patient tells you is wrong with them. All right. So if they're unresponsive, their chief complaint, all you really have is that they're unresponsive. Conduct a history of present illness, nature of force involved, direction and strength of force, protective equipment used by patient, actions taken to prevent or minimize injury or area of pain and injuries resulting from incident. So whenever you're talking about nature of force involved, you're talking about is a head-on collision, was it rear-end collision, rollover, a direction and strength of the force. So were we traveling forward and at 70 miles an hour, or were we traveling forward at 20? Big change there. So protective equipment used by the patient, do they wear their seatbelt? If that's a motorcycle wreck, did they wear their helmet? And were airbags deployed? Actions taken to prevent or minimize injury. Okay. Areas of pain, injuries, areas of pain and injuries resulting from incident. So my legs hurt because I jumped off a ladder or fell off a ladder. My face hurts because I ate the steering wheel. My hand's getting tired from holding my thing. Areas assessed depend on injuries and chief complaint. Mechanism of injury may point to potential injuries. And 3 techniques: observation, palpation, and auscultation. that lady, yeah. Perform a physical examination of the relevant body systems, respiratory, cardiovascular, neurological. And, this actually should have been more in the medical section. Physical examination, observe for abnormalities in symmetry, color, shape, and movement. So if they have a hinge joint mid-calf, that's really not a normal thing for people to have. So there's a good chance that they have a fractured leg, right? So, color, are they bruised? You could also look at skin, are they pale? Shape, is it swollen? So on and so forth. Palpate for abnormalities in shape, temperature, texture, and sensation. Auscultate for decreased or absent breath sounds. DCAT BTLS. This is another mnemonic that you guys will need to learn, and it's something that I'm terrible at. I'm terrible at DCAT BTLS. It came after I got out of paramedic school. Or right towards the end. So deformities, contusions, abrasions, punctures, and penetration, burns, tenderness, laceration, and swelling. If I sit there and think about it real hard for a long time, then I can think of it all. It'll take me longer to think about it than it takes me to do my head-to-toe examination and find deformity, contusions, abrasions, punctures, and penetrations, burns, tenderness, laceration, or swelling, at which time I denote. Obtain baseline vital signs and a past medical history. After a physical exam is conducted on a trauma patient, then assess his baseline vital signs and take a past medical history. Use sample and other pertinent questions when examining the patient. So after physical exam is conducted on a trauma patient, then assess his baseline vital signs and take a past medical history. Use sample and other pertinent questions when examining the patient. So sample, same as before. Signs. Well, now they're doing signs and symptoms, right? Allergies, medications, past pertinent medical history, last oral intake, events leading to injury or illness. We already went over that in the medical side. Applying a cervical collar. Apply if mechanism of injury, history, or signs and symptoms indicate use. If they've been in a rollover accident and they want you to transport them for evaluation, I would put a C-collar on them, even if they're not complaining of neck pain. Oh, I hit my knee and I need to go get it checked out. Okay, great. We need to put the C-collar on you. Because why? There's a high mechanism of injury in a rollover accident. So on the other hand, we talked about, I slid out of my wheelchair. You probably don't need to put a C-collar. Make sure collar is correct size. One thing that makes me cringe is whenever you get a department that has a culture of everybody gets a no-neck C-collar. All right, I'm looking around here and I see maybe one no-neck C-collar. Most everybody in here will do at least a short C-collar. And so whenever we do no-neck, we're just really being, at least, I said at least, you guys are taking this way too serious. Not everybody's a no neck. Most people aren't. You're not doing any good. It's not stabilized neck. Understand a C collar is not going to prevent movement unless you use what Roger Mills County uses, which is the X collar, and it does prevent movement. The thing is you might want to hang out and tell the nurses what the heck this thing is, because it doesn't work the same as the C collar. It works better, but how it is applied and everything is different. You have to get good at putting them on. I'm terrible at putting them on, but I believe in them. What's that?
Which one were you talking about?
We use a C collar called X collar. It's different than your typical EMS cervical collar. So here's how you apply. Here's how you apply for a C collar. So you measure from that line of the jaw to the shoulder, okay, with your fingers. So measure the patient's neck. There's going to be a gauge, and we will go over C collars a little bit later on. There's a gauge in the C collar that will help you measure. So it'll say like edge of collar to, and it'll be like a red line. If let's say that you measured with 3 fingers, if you put the 3 fingers on the bottom edge of the C collar, and it goes over that red line, you need to go down in size. If the red line's way above it, if your fingers go over the red line, you need to go up in size. If the red line's way above your fingers, you need to come down in size. So measure the collar. The thin piece should not lift the patient's chin and hyperextend the neck. Make sure the collar is not too small or tight, which would make the collar act as a constricting band. If it's too big, you're going to make the patient's head look up. That's not keeping it in line or as the collar is intended. If it's too small, they're just going to be able to move their head all around. Once again, that's not what it's intended to do. And with a regular C collar, you're not going to prevent all movement. It's more of a reminder for them to try to hold their head still. So applying a C collar, assess patient's neck prior to placing collar, reassure patient, size collar, remove jewelry, and move hair. I'm terrible about removing earrings. I'll try to at least get like you have hoops in. I'll at least try to get them outside of the C collar, because if not, it's going to press on your head and push into your head. And like even studs, if you get a stud underneath the C collar, I'll try to pull your ear out so it's not poking you in the neck. Oh, you got both. So keep the patient's head in the inline anatomical position. Slide collar into place from the front. Like I said, we will go over C collars. Did you get food?
I got food.
Lucky you.
Delivery.
Man, you have like an inn, huh? You have an inn. You're like, people won't bring me food.
You're not
They didn't ask you.
special.
I told him I was
They
ordering.
didn't ask anybody nothing, they just went out and did it.
Really, they just sat there.
Okay, are you sure you're not- did you eat anything?
I'm talking to somebody else from me. Whatever. Okay. Wow. Okay. I'll be there. All right. I'll be more for this area. Bye, thank you.
Hey, you got any Neosporin in here, like with those packets?
No, I don't. Promise, you can look.
No, nothing, no Vaseline, no nothing?
I have water soluble.
Or you thought we put on his nose?
What do you do to his nose?
It's this dry and nasty.
You know what?
Where'd it go? I already spilled out.
Yeah, I
He's
don't know.
been just blowing his nose like crazy, and it's sticking, it's cracked and all.
So applying adjustable C collar to a seated patient. We'll go over these things. The collar alone does not provide adequate inline immobilization. Must be paired with manual stabilization or fixation to a long spine board. Adjustable C collar is exact same. Measure, adjust. I'm good. Thank you. I'm just kidding.
She gave me 2 things so I can share with somebody.
No, I'm good.
You know, for the one.
I already ate something. Collar alone. Okay, so anyway. The adjustable, you go ahead and do your measurement, adjust it, and then lock it into place. X collar is a little bit different. You actually adjust it while you're placing it, so it's a little different. Trauma patient with serious injury or multi-system trauma, high priority. Continuous spinal mobilization. Consider a request for advanced life support or ALS personnel. Guys, I will tell you, I don't necessarily agree with this unless you're dealing with spinal shock. The reason is because there's nothing I'm going to do for this patient that you can't do yourself unless they're in spinal shock. If they're in spinal shock and their pressure's going down, and they're, you have a high heart rate, and you start to drop your pressure. Yes, I could do some medications and things like that to keep them, but if it's just a patient you suspect a spine injury on, I'm going to do the exact same thing as you. and just transport and sit there and talk to them. So. Secondary assessment, trauma patient with significant injury. Rapid trauma assessment, rapidly assess each part of the body. Head, check for wounds, tenderness, and deformities, plus crepitation. It's gross. Find it. Performing a rapid trauma assessment requires only a few moments. Should be performed at scene. Care provided en route will be based on this assessment. Oh gosh, I hate when they put such hard rules like that. So if you find something that, yes, your care will be based on this, but guys, we're in a very dynamic atmosphere. It's always changing. So if you find something, you can adjust your treatment. Rapid assessment of the head, so palpation, cranium, face, ears, eyes, nose, and mouth. Looking for that decap BTLS. Whenever you're talking about mouth, you're also looking for loose teeth, any blood in the airway, things that you need to suction out. Blood or clear fluid are serious findings. Clear fluid, if you're talking about in the mouth, coming out of the ears, or anywhere around the head, clear fluid is typically going to be a CSF or cerebral spinal fluid, which would indicate that you have a skull fracture. More precisely, if it's coming out of the ears or nose, it's a basilar skull fracture. Rapid assessment of the neck, wounds, tenderness, deformities, and jugular vein distension. Stoma or tracheostomy. Hey, there we are. We're talking about a few more of the things that I told you guys. Why are we concerned about tracheostomy? You're full of snot. Yeah, because on a trauma patient, you need to make sure that whenever you place your C-collar, you have clear access to that trach. All right. So, rapid assessment. Rapidly assess each part of the body, chest, auscultate for breath sounds, presence or absence, and equality. So, are they equal breath sounds? If you're an absent breath sound and you have some trauma to the chest, there is a chance that you have a pneumothorax. My goodness. The other reason I'm going home tired. So, rapid trauma assessment, rapidly assess each part of the body, chest, inspect and palpate for wounds, tenderness, and deformities, plus crepitation and paradoxal motion. Paradoxal motion, I'm not going to play tonight. I'm not going to play it Saturday because people have plans, but remind me on Tuesday's class. Actually, I'll try to have it up for whenever you guys come in and show you guys video of paradoxal motion of a person breathing, a flail chest segment. It's very impressive, and so it's pretty cool to watch. And I've never seen, maybe one, I guess, but it's very rare to see it. It's a very bad chest injury. When you break that many ribs in that many places is a high energy transfer. Most of the time, people are dead. Perform a rapid trauma assessment, application of cervical collar, size and apply if indicated by protocol, or gut. You guys have the ability, if the protocol doesn't say that you have to put it on this patient, you guys are like, you know what, I just don't feel right about this. There's something going on. I feel like you need a C-collar. If you have that feeling, place that C-collar. Don't ever discount that gut feeling. Rapid assessment of the chest, paradoxal motion, crepitation, and breath sounds. Rib cage and chest must be exposed. I told you guys before what paradoxal motion is. It's where a section of the chest wall goes in an opposite direction. So as you take a breath in and your chest wall normally goes out, there's a section or a side that rather than go out, it goes in. It goes in the opposite direction of what it normally should, or what the rest of the chest wall is doing. Rapid assessment of the abdomen, distension, pulsating masses, gently press down on quadrants. Don't overly palpate the pulsating masses, please. Rapid assessment of pelvis, bleeding, priapism. You guys all know what a priapism is, I hope. If not, it's an erection caused by spinal injury. Yeah. And you found there is also some neurological medications that can also cause said infliction. Rapid assessment of the extremities, tenderness, deformity, circulation, sensation, and motor function. If they're unresponsive, you still want to try to at least get pulses. Make sure they have equal pulses. So. What's that? No. Extremities.
Thank you. That sounded like that.
So rapid trauma assessment, rapidly assess each part of the body. So abdomen, check for wounds, tenderness, and deformities, plus firm or soft and distended areas. What do you guys think a abnormally firm abdomen or a firm abdomen would be from? A firm abdomen. What do you think would cause a firm or what you would know as a rigid abdomen? They've been doing a lot of crunches that day.
Yeah.
Even those patients, whenever you palpate their abdomen, it's going to be soft and pliable. But if you go to palpate their abdomen, it's like hitting a board. There's a good chance that they have an abdominal bleed. There's blood collecting in there, and it's made that rigid. Rapid assessment of the posterior body and immobilization on a backboard. Whenever you do a posterior evaluation, especially if you're going to be transporting this patient on a long spine board, log roll them up onto their side, check their back and posterior, back their head, back their neck, and then whenever you roll them back down, you're going to roll them back down onto that long spine board. So obtain baseline vital signs and past medical history. Use pulse oximeter if applicable. So there's what a log roll typically looks like. Here's a medic assessing the back. Check for wounds, tenderness, and deformities, and knives sticking in their back. Believe it or not, it's happened. Don't roll them back onto their back if they have a knife sticking out of their back. Yeah, exactly. Some general principles: communicate with patient, expose injured area before examining it, maintain eye contact. What are we making love here? Assume spinal injury, stop or alter assessment process to provide care. Jimmy Christmas.
They're getting up close and personal. We're trying to figure out what's going on with this person.
Maintain eye contact.
We're trying to figure out what's going on.
How you doing? You know, so,
Later on, so either they'll snap out of it or
yeah. Whoa, get away from me. What the maintain eye contact? Whatever.
in some cultures.
Yeah, exactly. You're like, hey, I'm maintaining eye contact here.
That word in that chapter makes me so mad.
What's
It's a
what is it?
Because it says, really big letters, maintain eye contact. You say, you're really big on it. This is don't look at those people who like shy away from you. Well, what the hell do you want me to do? You want me to maintain eye contact?
You're gonna do like this, you're gonna be like this, you're gonna be.
Nope.
I know. It's for dollars out.
So assess distal circulation sensation for motor function. So here it is. They're checking for a pulse. Assess distal circulation in the upper extremities by feeling radial pulses. What the?
They're getting all mixed up.
There we go. But I feel like they have. So assess circulation sensation motor function. So motor function, the patient. So you're going to check the patient's ability to move both hands. And then assess strength in the hands by asking the patient to squeeze your fingers. Check distal circulation in the lower extremities by feeling the posterior tibial pulse. So they're feeling it in the ankle there, just behind the medial malleolus of the ankle. The medial malleolus is that big knot that you call your ankle. the ankle bone. Lesser mechanisms can cause significant damage. Pediatric, explain assessment more thoroughly in this population. Think about it. What criteria would you use to decide whether to perform a focused physical exam or a rapid trauma exam? I used them all. You want to use mine? I got cuties. Orthogonosyphilis. Why the hell am I even up here talking?
You got another picture of the, yeah. you got
So rapid trauma exam is more of your critical patients, right? So your critical trauma patients, you're gonna get that rapid trauma exam. We'll play this video.
The most valuable tool an EMT can possess is excellent patient assessment skills. While there are differences between how we assess medical and trauma patients, the initial approach is largely the same. Take standard precautions for body substance isolation based on what you know of the call. Gloves and goggles are a minimum for every call, but you may need a gown for massive bleeding or face mask if airway management is going to be required. The scene size-up actually begins with your dispatch information. What you are told about the location of the call and complaint can give you information about what to expect when you arrive. For example, if you are responding to a martial arts studio, you might expect a fall or musculoskeletal injury. Upon arrival, ensure the situation is safe to enter, meaning that there are no hazards to the safety of you or your crew, such as a loose dog, poor lighting, or a fight in progress. Determine the number of patients who will need your attention and whether or not additional resources, such as ALS responders, law enforcement, hazmat, or the power company will be required. Call for help now if additional resources are needed. Once the scene is secure and additional help has been called if needed, determine the mechanism of injury based on the patient's chief complaint and initial presentation, or if the patient is unconscious, bystanders or scene clues such as an overturned ladder or vehicle deformity may give you important information. If the patient has been involved in any type of fall or blunt force trauma, or presents to you on the ground without explanation, begin manual immobilization of the spine now until you are able to confirm that a spinal injury is unlikely. Your primary assessment should be done the same way every time on every patient. The purpose of the primary is to find and correct life threats, such as apnea or hemorrhage. Having a consistent approach to the primary assessment will ensure that you identify the most pressing, life-threatening issues with your patients every time. The primary assessment begins when you determine your general impression of the patient. This is often stated as a level of distress, such as mild, moderate, or severe, sick or not sick, or as an obvious injury, such as head trauma or a suspected leg fracture when deformity is readily apparent. Next, determine the patient's level of consciousness. Discover whether they are alert when you come in, meaning they are aware of your presence. If they do not seem aware that you have arrived and are presenting with their eyes closed, attempt to gain their attention by using loud verbal stimuli, and if unsuccessful, appropriate painful stimuli, such as intradigital pressure. If they do not open their eyes or speak to the verbal or painful stimuli, they are said to be unresponsive. Regardless of level of responsiveness, introduce yourself and attempt to gain consent to treat the patient. Of course, you may treat an unconscious patient using implied consent. If the patient is alert, ask them for their chief complaint or the main reason you were called. In the event of an unresponsive patient, you may be able to determine the problem from bystanders or the scene itself. Your assessment of the airway is next. You will need to confirm that the airway is patent, and if not, open it now using a jaw thrust technique to avoid compromise of the cervical spine. Look inside the airway to make sure that there are no obstructions or substances that need suction. Clear the airway now. In a situation where it appears that the patient is unable to maintain a patent airway, such as in a patient with an altered level of consciousness, insert an OPA or NPA now. Assessment of breathing comes next, including respiratory rate, rhythm, and quality. You will also need to determine if the patient has adequate tidal volume. To begin this assessment, you should bare the chest to check for any wounds or bleeding. If an open chest wound is apparent, an occlusive dressing should be applied. Also look for medical alert tags. It is not uncommon that a medical emergency precedes a traumatic event. A bare chest will also help you to listen to lung sounds without interference from clothing. In addition to auscultation and inspection of the chest, you will need to palpate the chest wall for stability and to ensure that the patient doesn't have subcutaneous emphysema, crepitus, or pain on palpation.
Good thing I told you guys what
Oxygen
subcutaneous
should be
was,
applied
right?
now if it is indicated. For respiratory rates less than 10 or greater than 28 to 30, or for inadequate tidal volume, ventilation should be assisted using the bag valve mask attached to 100% oxygen.
So
The
24
radial
or
or
28 to
carotid
30?
pulse can be used to assess circulation of a trauma patient. If a radial pulse is
I'd
not
read more
present due to
28 to
poor
30.
perfusion, move to the carotid pulse. Check for pulse rate, rhythm, and quality. Assess the skin for color, temperature, and moisture. Another way to assess for distal perfusion is by checking capillary refill time by putting pressure on the nail bed and counting the number of seconds for blood to return to the area after it is blanched. Normal capillary refill time is less than 2 seconds, indicating adequate distal perfusion to the extremities. Control any major bleeding if present and possible. You can begin to control external hemorrhage with direct pressure. In some situations, a patient will present with internal bleeding. Internal bleeding from, say, a liver laceration or damaged kidney obviously cannot be controlled by EMTs. Therefore, you will need to begin treatment for shock, which includes lying the patient flat and covering him or her with a blanket to preserve body heat. While you already determined level of responsiveness using the AVPU scale, it is now time to determine level of orientation using the patient's answers to questions about their name, time of day, current location, and events leading up to the EMTs being called. This is called alert and oriented times 1, 2, 3, or 4, depending on how many questions about person, place, time, and event they answered correctly. You could also use a Glasgow Coma score to report level of consciousness in trauma patients. Now is the time to assess pupil size and reactivity to light as another measure of neurological activity or disability. In some situations, a patient will present with major trauma. Major trauma patients need to be fully exposed with their clothes cut off or otherwise removed. An isolated injury, such as an ankle fracture, could have just the area involved exposed. Based on the information gathered in the primary assessment, identify and treat any life-threatening conditions. Any insult to airway, breathing, or circulation, or neurological disability, including altered mental status, indicates a critical patient. If the patient does have life-threatening conditions, begin packaging and transport now. In a situation where no life-threatening conditions exist, you will likely stay on scene for a while to gather more information, take vital signs, splint injuries, and treat for pain. While vital signs are actually the first part of the secondary survey, it is unlikely that you will take these yourself as you will be busy talking to the patient. It is appropriate to delegate vital signs to a partner so that the information can be gathered simultaneously during your history taking. Note that in the critical trauma patient, the history, secondary assessment, and reassessment are all performed en route to the trauma center. First, gather a history of present illness by asking the patient what happened today to make them call EMS. The mnemonic OPQRST can help explore a complaint of pain. O stands for onset. You would ask what the patient was doing when the pain started,
All right.
or what
We talked
caused
about
it.
most of this, and you
P
guys
stands
So detailed physical exam. Typically completed en route to hospital, gathers additional information, completes primary and secondary assessments, performed after all critical interventions completed, and primary assessment reevaluated again before initiating. For these patients, you will have assessed almost the entire body during rapid trauma assessment. Now need to assess the entire body more thoroughly to possibly reveal signs or symptoms of injuries you can have missed or have changed since the rapid trauma assessment. Remember before the detailed physical exam, remember to perform this only after you have performed all critical interventions. If you are treating a severely injured patient and are too busy to complete the detailed exam, it is not a failure. All right, so don't worry about your sample and PSP history if you're doing all this. So it is your responsibility to give the patient the best care possible, which may mean skipping the exam in order to maintain airway, breathing, circulation. Exposed patient, work around immobilization equipment and components similar to rapid trauma exam, just more detailed and focused. So now rather than just going through and doing a quick sweep of the leg, you're actually feeling the leg to see if you can find any crepitus or deformities, and you carry that out throughout the whole body. You're going to check for equal expansion and excursion. Generally does not need a trauma patient who is not seriously injured generally does not need a detailed physical exam. Keep a high index of suspicion, and when in doubt, perform a detailed physical exam. And be aware of patients' fear and need for emotional support. Also be aware of, if you're cutting, let's say if it's a 2-woman crew, cutting a young kid, 18, 20-year-old boy, clothes off. And the same thing with me whenever I'm with just me and another guy, EMT. Now, if I have a woman with me, I typically like the woman to cut the female's clothes off. But sometimes it doesn't happen that way, and just explain, hey, we got to cut your clothes off, we got to look at you, we can't take them off because it might further the injury, and just explain, let them know what's going on. Think about it. Is it necessary to always complete a detailed assessment on a trauma patient with no significant mechanism or injury? No. It said that like two slides ago. So do we even really need to think about that? Think about it. Do we even really need to think about it? Mid-chapter review. The patient without a significant mechanism of injury receives a history of the present illness and physical exam focused on areas that the patient complains about and areas that you think may be injured based on the mechanism of injury. Next, gather a set of baseline vital signs and a past medical history. For the patient with a significant injury or MOI, mechanism of injury, ensure continued manual stabilization of the head and neck. Consider whether to call advanced life support personnel if they are available, and get a brief history of patient's illness and perform a rapid trauma assessment. In the rapid trauma assessment, look for wounds, tenderness, and deformities, plus certain additional signs appropriate to the part being assessed. As summarized in Table 14-8. Bam, you got 14-8. Systematically examine the head, neck, chest, abdomen, pelvis, extremities, and posterior body. Basically, you're going to run it head to toe. After assessing the neck, apply a cervical collar. After completing the physical assessment, immobilize the patient to a spine board and get a baseline set of vitals and a past medical history. After you have performed the appropriate critical interventions and begun transport, the patient may receive a detailed physical exam en route to the hospital. The detailed physical exam is very similar to the rapid trauma assessment, but there's time to be more thorough in the assessment. The detailed physical exam does not take place before transport unless transport is delayed. Why would transport be delayed? They were stuck on scene. Yeah, we're stuck on scene waiting. It happens.
We're going to do a detailed exam if you're waiting on that, or you're just going to.
Yeah, you know what? That'd be a good time to start a detailed physical exam. But some things that I'd have before I worried about detailed physical exam, I'd make sure, if I can, if it's possible, name, age, date of birth, medications, allergies. Get them a nice sheet, list your vital signs that you could just hand over to them, and then start performing your detailed physical exam. So the detailed physical exam is most appropriate for the trauma patient who is unresponsive or has significant injury or unknown MOI. A responsive trauma patient with no significant injury or MOI will seldom require a detailed physical exam. We don't have to go all the way up and come down and take it inch by inch. Reassessment is where we'll start whenever we come back. Let's see where we're at on slide wise.
No, but reassessment already has like 4 pages.
We're at 116. We're at 116 of 164, which makes it very doable for us to get through the rest of this and chapter 15, probably 16 on Saturday. I don't want to be here till noon on Saturday, but I'd like to. Maybe we start at 8:30 on Saturday.
I wasn't here.
No, that's fine. That's fine. So let's start at 8:30 on Saturday and try to get done.
I will start at 8:30 as long as we do get done before then.
I just hung up on him, didn't I? Are you guys still there?
You didn't even tell them bye. You're mean tonight, bro.
All right, guys, I'm out of here. Sorry. Glad it's done. I just hung up on you guys without even stopping it. I'm going home. I'm tired.
Did you have to work?